StiL NHL1 trial was now again confirmed that the bendamustine rituximab is a very good first-line treatment with a good outcome, and it has many advantages in comparison to R-CHOP, and it has, at least in my analysis, no disadvantage compared to R-CHOP. And even the strongest endpoint, the overall survival, speaks in favor of bendamustine rituximab. So the PRIDE trial was similar but not the same, and the PRIDE trial was not as clear as our trial because there was two factors which can be discussed. For example, it was up to doctor's choice to use CVP or CHOP-R, so maybe there's a little bit patient selection bias in that comparator group if you use CHOP or CVP-R. Second, it was only planned to look for the complete response rate as a primary endpoint. Only secondary endpoint was PFS, and it was not planned to follow up. And then they found that the progression-free survival even was better as a comparator arm. However, there also was no predefined strategy for the doctors, because once the complete response was evaluated, then the doctor was free of his decision. No follow-up was planned. That means that, as presented, 50% were treated with maintenance. So that again makes the whole study not so very easy to interpret, because maintenance has any influence. And so Brett Carl has interpreted this also, and I agree with him. In my study was just the clear comparison of BR against R-CHOP, and BR, as he said, beats R-CHOP. In the PRIDE trial, also BR beats R-CHOP and R-CVP, however, not in the same extent as me. And he thinks because maybe the maintenance has influenced to improve the weak comparator like CHOP-R. That was his theory. And I don't know if that is true, but it's a potential explanation, and that can be debated, and therefore I think the results from the PRIDE trial are very important to show that the PFS was even better again. And then second, we have to be cautious with the final conclusions because of that maintenance issue and the issue that the comparator arm was based on doctor's decision to give CVP or CHOP-R. And then, of course, what was the issue of discussion was this high incidence of the secondary malignancies. And Ian Flynn made the statement that this has something to do with the skin cancers and the squamous cell cancer of the skin and the basal cell cancer of the skin. And we have not seen it. However, I already made this comment while I presented that maybe we have underreported it, because this is not a life-threatening disease, and some patients may not report it if we follow up them because they went to the skin doctor and they got a little surgery and the problem is solved. So I am not quite sure if that has any influence on this problematic secondary malignancies. At least I find myself very reassured that the overall survival curve in my study did not show unexpected high death rate in the end. Patients should be treated with stem cell transplantation. At least this is a consensus, and so the whole strategy would go into to make it possible to have high dose treatment with stem cell transplantation. The second most important thing is to include high dose of RSC to the young patients. And then the third question is, what is the chemo backbone? That is under debate. Some doctors use hyper-CVAD. I'm not convinced at all. Some doctors use R-CHOP, and I think R-CHOP is not a good treatment. So why not implementing bendamustine rituximab, alternating with high-dose RSC followed by stem cell transplantation, or just rely on bendamustine rituximab? And maybe you can combine it like the R-BEC regimen in a triple combination, bendamustine, RSC, and rituximab. So This is an open debate, what is the best treatment for the young patients, but for the elderly patient with mantle cell lymphoma, I agree, bendamustine rituximab is an excellent choice, and I have followed many debates in the world, and there's rather something like a consensus that bendamustine rituximab is a very good recommendation for elderly patients who cannot go to stem cell transplantation. So when you know that the patient is not fit enough for stem cell transplantation, bendamustine rituximab is a very good choice and maybe a preferred first-line treatment for elderly mantle cell lymphoma patients. And in low-grade lymphoma, I just have to follow my own results. The results speak a clear language. I would prefer in any circumstance, if it's a low-grade lymphoma, to use bendamustine rituximab as a first-line treatment. This was a statement from Brett Kahl, who made the interpretation after the two presentations about bendamustine, and this is his speculation, extrapolation, and his hypothesis, and this is clear to say and to discuss. That's his opinion. Of course, we know that this is not based on evidence because there was never a randomized comparison of these two strategies, but when you just look at the overall survival rate at 6 years, one can get this impression that one can say such a strong statement. So it's science and its interpretation and its evaluation of the results and making opinion what would be the best, because usually the study just answers one question: is BR better than CHOP-R? But not to say is BR as good as CHOP-R plus maintenance.